Good evening, at least it's evening in Los Angeles, and welcome to our next next version of Urology 60 Minutes. As many of you would know, this is a weekly Thursday conference that we have been doing from the department. And also, please remember that the contents of this 1 hour session are being recorded and then will be displayed in the USC Urology YouTube channel, where many thousands of people, urologists, come in and look at the content later, and you're welcome to do that. Our topic today is an exciting one: management of clinical stage 2 germ cell tumors. And as usual, we have an outstanding faculty who are participating. Dr. Robert Hamilton is from the University of Toronto in Canada. Dr. Christian Kollmannsberger is from the University of British Columbia in Canada. And Dr. Craig Nichols is the executive officer of SWOG based in San Antonio, Texas. These three are leaders in the field, and it's a real pleasure to have them join us here in this 60 Minutes edition, which is going to be hosted by the USC's faculty, Dr. Daneshmand. He is Director of Urologic Oncology in our department and himself a leader in testis cancer. So welcome to this edition, and over to you, Dr. Daneshmand, for the course.
Great. Thank you very much, Indy. And we're still trying to get Dr. Hamilton on. We'll start, and hopefully he can join us in short order here. So again, thank you for that introduction. I mean, we have some of the top testis cancer experts in the country, and we're going to start talking about management of stage 2, which can have a lot of nuances. And I think we can get a lively discussion going here. So we'll go ahead and get right into it. Again, thank you to the participants, Dr. Kollmannsberger and Rob Hamilton and Craig Nichols, who have agreed to come on and share their opinions and expertise with us. So I'll go ahead and get started here. Hopefully everyone can see that. Okay, so management of stage 2 germ cell tumors, and I put surveillance there. You're thinking, why would you do surveillance on stage 2? But we'll talk about that. Chemotherapy or RPLND, something that's not done very often. So I have no disclosures pertaining to this talk, and again, we're going to go straight into a case. This is a 35-year-old gentleman who presents with a left testicular tumor. Most centers is around 10 to 12. Beta HCG is slightly elevated. LDH is normal. He undergoes a left inguinal orchiectomy, and pathology shows a 6.5 centimeter pure seminoma. Retestis invasion, and it's confined to the testicle, but there is lymphovascular invasion, making this a T2. So 3 weeks post-operatively, his AFP is 14. So not much change from prior, as HCG does normalize and LDH is normal. Chest X-ray shows no metastases. And here's your CT scan showing a 1.6 centimeter para-aortic lymph node in the landing zone. So this is something we would deem to be stage 2A. And we'll go ahead and talk about principles from AOA Guidelines. A statement that we should establish nadir levels of the tumor markers before treatment. That's just a clinical principle. And that borderline elevated levels of AFP and HCG should be interpreted with caution. If you have elevated and rising post-chemotherapy, post-orchiectomy AFP and or beta HCG, that's probably systemic disease. However, keep in mind that you can have false positive AFPs and HCGs from liver disease, hereditary tyrosinemia, and hereditary persistence of AFP, that can give you a false elevation and throw you off. I told you this is a pure seminoma, and as most of you know, pure seminomas should not be producing AFP. In fact, if you do have an elevated AFP, that would be a non-seminoma. So there's a paper we published with University of Chicago, Johns Hopkins. Actually, this was led by Scott Egner at University of Chicago, looking at 705 consecutive cases and 10 with this elevated but stable AFP of less than 30. And if you can look at these cases, all 10 of them were followed for quite some time, and a number of them were treated with chemotherapy and RPLNDs and things like that, and their AFP never really changed. So don't treat an elevated AFP unless it's more than 30 and or rising. This is a really important point, and I wanted to bring it up in this first case. So again, AFP went from 15 to 14, but that should not come into the management. So the NCCN guidelines tells us that for pure seminomas, you can either do, for 2A, we can either do radiation therapy or primary chemotherapy with 3 to 4 cycles of BEP versus 4 of EP. The cure rates are excellent. So with that, I'll stop here and ask Christian to give me his thoughts on this case. Let me just stop sharing. Okay.
So do you want me, do you want just a discussion, or do you want me to bring up the
Go ahead and bring up,
talk?
Yeah, go ahead and bring up your slides.
Just a second. So yeah, there we go. Can everybody see that?
Yes.
Yeah. So thank you, Sia, for the invitation. It's always a great pleasure to discuss these things, and it's always exciting to discuss stage 2 because, as you said, there is a lot of nuances to it. So this is just for illustration, similar to what you just showed, and I don't really want to go into because it's more or less exactly the same thing. You have these patients who have a orchiectomy, and then either at the time of orchiectomy or after that, they develop these borderline-sized lymph nodes somewhere between 1 and 2 centimeters. And the question is always: is this true disease? Is it really a stage 2A, and is it a metastasis? Is it really a pathologic stage 1 and the lymph node is something else? And that is a diagnostic dilemma, because we know that there is a number of cases where the lymph node is simply a false positive finding. That has been shown, particularly in the non-seminoma world, in the original RPLND series, where in some series up to 40% marker negative clinical stage 2As were actually pathologic clinical stage 1 at the time of primary RPLND. I think if the markers are elevated and are going up, I think there is no doubt that this is disease. But a real problem is the marker negative clinical stage 2A, where we know that a number of patients do not have actual disease. So there's a high uncertainty. And in the testis cancer world, one of the dominant principles is really that we should not treat our patients unless we really have to, and we should try to cure our patients with the minimum in toxicity and avoid unnecessary treatment. And a few years ago, Craig Nichols and a few of us, we kind of proposed these overriding principles for the treatment of germ cell tumor patients. And when you look at that, these underlying principles, you will understand much better what angle we take when we think about a clinical stage 2A. So the prognosis of stage 2A patients is excellent. We know that we can cure these patients in the very vast majority of patients. We know that there is some uncertainty because, particularly in the tumor marker negative non-seminomas or in seminomas, up to 25, maybe 30% of patients may not actually have disease. And most importantly, there is to date no reliable imaging modality which really allows the differentiation between active tumor from inflammation, scar tissue. And no, and I emphasize that here, PET is not reliable either. We see that frequently, that PET is then used and decisions are made on PET scans. And at least to date, it has not been shown that PET is absolutely reliable either. And then most importantly, since we know that we can cure these patients with various modalities, the quality of life is a really important driver of decision-making in clinical stage 2A disease. These are young patients. What happens 30, 40 years down the road is extremely important to them. We're not talking about 70 or 80-year-old patients. So we should definitely avoid treatment for patients with benign lymph nodes. And the reason why we should avoid treatment, because irrespective of what you do, radiation, chemotherapy, there is a certain price to pay for that. We have acute toxicity, and particularly with chemotherapy and radiation, we have late toxicity. And we will talk about where RPLND comes in here for clinical stage 2A, because I think, and I'm sure we will talk about that, RPLND will actually regain some importance for the treatment of these patients. And because of these acute and long-term toxicities, it is really important that we carefully select our patients who need these kind of treatments. So we wrote a paper 2 years ago or so, which we entitled Treatment of Clinical Stage 2A Testis Cancer, Be Sure, Be Patient, Be Safe. And that basically reflects this kind of selection process. And when you look at this, if you have a clinical stage 2A, and this is for seminomas now, because your case was a seminoma, if you have unequivocal or biopsy positive metastatic disease, yes, then the patient can be treated with chemotherapy or radiation. But the majority of patients, you don't have that. And what we do in these patients, if a patient shows up with this 1.3, 1.4 centimeter lymph nodes, I usually just tell them to come back after about 8 or 10 weeks, and we repeat imaging and see whether there's actually growth to that lymph node or not. It does not alter his prognosis. The cure rates will remain the same, but it gives you that safety, and it allows, if this is a false positive node, the node to potentially shrink again, and to avoid unnecessary chemotherapy in these patients or radiation. Now, ideally, what we would have in order to help us in this dilemma, where we are not exactly sure what we are actually dealing with, would be if we had a biomarker, easily measurable biomarker, which would tell us there is tumor or there is no tumor. And it appears that plasma microRNA 371 may be that biomarker, which in the future may be able to help us out. MicroRNAs are small non-coding RNAs, which regulate expression of various oncogenes. And we know that microRNA 371 is expressed in more than 90% of germ cell tumors, and it is expressed in seminomas and non-seminomas. The only problem is that it is not expressed in teratoma. It is highly specific for germ cell tumors. Really, the only other condition is pregnancy. That doesn't really play a role here. It has been shown that serum levels appear to correlate with clinical stage. And if once the tumor is treated, microRNA rapidly decreases and disappears after successful treatment. So it is easily measurable. It's a relatively cheap test. It's not rocket science. So it has all the features of an excellent biomarker, which we could potentially utilize. Just to illustrate that in an example, this is a patient of ours who had a seminoma, and about 3 months later, he showed up with this very small lymph node, which you can see here. He had a PET scan done outside, which was highly positive. In this patient, the microRNA was negative. A biopsy showed follicular lymphoma. So I think if we just clinically see this with a history of a seminoma in 3 or 6 months ago, nobody would doubt that this is probably tumor. We would have given him chemotherapy. We would have probably treated him well, because that lymph node has a high chance to have disappeared. And then 5 years later, he would have had a recurrence, and we would have said, well, now he has lymphoma. So I think that just illustrates the potential a good biomarker can have for these patients. And there is, we showed that in a publication which we published in JCO last year, and there is now a large SWOG study ongoing, which looks at the value of this biomarker in clinical stage 1, and soon another SWOG study which will look at it in clinical stage 2 as well. This is another patient, 39 years old, had a classic seminoma, resected in 2015. 3 years later, he has a small lymph node which subsequently grew. We did exactly what I said before. We just watched him. We did a CT scan 3 months later. As you can see, this interorthocable node got bigger. He got a PET scan within a study, and you can see that it was actually positive. However, when we did an RPLND, this was Sia's RPLND study, this patient had no malignancy found on RPLND. It was granulomatous inflammation. And when we correlated subsequently his preoperative microRNA, it was negative. So in this case, the microRNA would have had correctly predicted that patient as well. And based on our results, microRNA is an excellent biomarker that has the potential to really improve our patient selection for active treatment and change the way we treat these patients. Thank you very much.
Okay, great, Christian. Thank you so much. So let me just continue, and I think we've got Rob coming on in just a second. But as you mentioned, you know, these are we got to be careful with these. Some of these 2As are actually stage 1s, and let me just. Okay, so we know there's long-term morbidity from chemotherapy and radiotherapy. We have excellent cure rates. There's years of potential cumulative toxicities with secondary cancers, metabolic syndromes, and bleomycin-induced pulmonary injury, and so on and so forth. Is there a treatment that can reduce the long-term morbidity if this is truly a lymph node, let's say that's growing and in the future microRNA positive? So I think there's going to be a change in paradigm. We know RPLND is effective in stage 1 and stage 2A non-seminoma and in the post-chemotherapy setting. And there's ample data to suggest that it has lower morbidity compared to chemo and radiation therapy. So we've been looking at RPLND for early stage metastatic seminoma for quite some time now. Had a very small series published with only 4 cases. But if you look at the literature, there's actually a lot more cases in case series altogether, but it's very, very limited. So this was, we had 4 cases. Most of them were stage 2A. There was 1 stage 2C. They underwent the open midline extraperitoneal nerve sparing, and there was some discordant staging, as you can imagine, upstaging and downstaging, but recurrence was 0%. This was a 2-year follow-up, but I can tell you now I have more than 5 years follow-up for all of these patients, none of whom recurred. And you can see the same thing in some of the other series. So this led to us looking at a trial. You can see the worldwide number of patients has been 26. That's what's been reported, but now more than 100 with stage 2A and 2B, early 2B seminomas have been enrolled in clinical trials. So the SEMS trial was surgery in early metastatic seminoma. The objective here was to evaluate the efficacy of first-line RPLND in retroperitoneal positive seminomas, 1 to 3 centimeters. Unfortunately, microRNA was not available at the time we started the trial, but we do have some data for some of the latter ones. This is just a publication by Nick Koss in Colorado that we participated in, just showing that most patients are willing to enroll in a clinical trial for low volume clinical stage 2 disease rather than undergo radiation or chemotherapy. So this was open at 15 centers around the country. We accrued really well. In fact, I had to increase the enrollment from 46 needed patients for this phase 2 study to 55 due to a rapid accrual. The endpoints are recurrence-free survival and treatment-free survival. Again, 15 institutions. We have not reported the outcomes yet, but we finished accrual actually last year, a year and a half ahead of schedule. So I'm waiting for our next big meeting to present the results. There's a similar study ongoing in Germany by Peter Albers. This is called the PRIME test, also looking at overall survival complication rates. Accrual goal is 30 patients, due to probably finish in the next year or two. He's now opened it up to multiple centers, and they're accruing 2A and B, including some very larger, tumors, although recently I think they've decreased the size criteria for that. So we were doing these midline extraperitoneal RPLNDs. The hospital stay is 1 day. Typically, you can see the midline scar is very, very small, and we can get the same exposure as before. So this is, again, a midline extraperitoneal nerve-sparing RPLND. You can see we get excellent exposure to all the relevant areas. There's a right renal artery. We can even get retrocrural, and there's a cruise of the diaphragm there. But this allows early return of bowel function, and basically we don't even wait for bowel function. Patients are given a regular diet and sent home the next day, usually if they have adequate pain control. So this is what the peritoneal envelope looks like. Are kept inside, and so you don't have the problem of ileus, nausea, vomiting, and all the other issues that go on with the traditional open RPLND with the bowels being mobilized all the way up to the chest. So it's a technique that most experienced surgeons, I think, can learn and hopefully, and again, we're making smaller incisions, they're healing very well, the patients are able to go home sooner and get back to life sooner. So that puts things into perspective as far as making treatment decisions. This is not the same morbid post-chemo RPLND of 10, 15 years ago. And here it's very, very low complication rate. This is from the SEMS trial. You can see we've had 5 complications, most of which have been grade 1 and 2. There have been 2 grade 3s. One was a chyloscytitis at one of the institutions and a pulmonary embolism. But all patients are alive, no deaths, injuries. Craig, I'm going to give you a chance to chime in here for a second while we talk about, before we talk about the next case.
Sure. And again, thanks for asking me to join. Always a pleasure and an honor. As you know, but so everyone else knows that this is a concept that we're taking forward or trying to take forward through SWOG and look at both seminoma and non-seminoma with the decisions regarding surgery be driven by biomarkers or serial observations, so we can reduce the false positive clinical assessments. And on that point, do you yet know what percentage of your patients were false positive clinical assessments?
Yeah, it's a great question. We don't have the final data in from the other institutions, but my sense is about 15 to probably 20% are going to be false positives, meaning we did the RPLND for a greater than 1 centimeter node. I know I had one that was 2 centimeters, turned out to be completely negative. So as Christian showed, these are the same as non-SEMS, where we're doing surgery or patients getting treated for tumors that were really not present.
And I'll remind everyone that these, if there's a 15 to 20% false positive rate, which I would tend to believe, we also need to remember that this is done in excellent centers that have a great deal of experience interpreting CTs and such. And we would expect, if we took a real world view, that it would be considerably higher. So one thing that is a feature of this study, as you know, since you're designing it, is that it's going to incorporate high volume centers as the base of operation, which I think is critical if we're going to take this forward to be practice changing. I think with the added potential of microRNA 371 and potentially 375, that we will be on excellent scientific footing to push this concept and reduce costs and late toxicities, which is the goal in 2A and small volume 2B disease.
Absolutely. Thank you. And we're very much involved in that and putting forth the next set of trials, which will help us reduce the burden of treatment for the patients who, we can reduce even the surgery that we do on at least 20% of the patients. So let's move on. Fortunately, we've got Dr. Hamilton on now. So thank you, Rob. Welcome.
My pleasure. Sorry about that. That's some of the worst technical difficulties I've ever had. We do Zooms all day, every day, and for whatever reason, this one couldn't.
I can't say it's a Canadian thing because Christian got on fine.
Must be an Ontario thing.
No problem. It's great to have you, and thanks for joining. So I'm going to move on to case number 2, and here's case number 2. Okay, so just get this out of the way. All right, so 28-year-old gentleman, he has a right testicular mass, AFP26, beta HCG12, LDH 140. He undergoes a right radical orchiectomy. The pathology shows as expected with dual marker elevation and non-seminomatous germ cell tumor, 40% embryonal, 10% teratoma, and you can see the rest there with LVI. So, so the CT scan of the chest shows no metastases, but the abdomen and pelvis shows this 2.3 centimeter para-aortic node, somewhat, cystic in some areas, solid and cystic, but it's now 2B, technically, it's greater than 2 centimeters. So options, primary RPLND versus chemo. Should we biopsy this mass or something else? Let me ask Christian. Christian, real quick, which one of these would you choose?
Is he tumor marker negative or positive?
Tumor marker is normalized.
Tumor marker is normalized, and he has a cystic 2.3 centimeter lymph node. I would probably 2.3 centimeters, correct?
Yeah. 2.3, yeah.
Yeah. In this particular case, I would probably choose a primary RPLND and send him to our surgeons. But we have to be aware that most of the guidelines recommend for a 2B upfront chemotherapy. But given the fact that he is marker negative, that the CT scan looks somewhat suspicious that he did have teratoma in the primary tumor, I would choose a primary RPLND here.
Okay. Craig, do you agree?
In short, yes. Personally, I don't really value the presence of teratoma in the primary specimen to make my decision. In this case, I guess my viewpoint, it's almost never wrong to start with an expert open RPLND in this setting.
Okay, great. So I just, again, wanted to reiterate this point, beware of overtreatment. Stage 2As can go on to stage 1 just on surveillance alone. You don't lose much by watching in short period of time. We don't want to, a borderline 2A, 2B to turn into 2C. This is a slide from Tim Gill again from Cleveland Clinic showing, over a 2-month period, this lymph node essentially completely disappeared and stayed. So I think Christian brought home that point. Rob, can you give us a few words on your thoughts here?
Sure, absolutely. And let me know if you want to, as you know, I've got a couple points on PowerPoint. We can either share or I can just talk, whatever you.
No, go ahead and share your screen if you can, and let's see your slides.
Yeah, sure. So I just have some brief talking points, but I agree with everything that's been said, and I think it's highlights the multidisciplinary nature of these particular cases, the importance of the multidisciplinary nature of these particular cases, the 2Bs. And it's really refreshing to hear Dr. Nichols and Kollmannsberger, medical oncologists, suggest that And I think the exact quote, Craig, was, "There's nothing wrong with a good old-fashioned open RPL&D." So it's good to hear that. And I absolutely, in this case, the cystic mass, solitary lesion, 2.3 centimeters. I do put some weight in teratoma in the primary in this case. And so we also would lean towards RPL&D as the upfront maneuver here. But in our clinic, especially for these 2Bs, we have a multidisciplinary discussion. We both meet with them at the same time to discuss the options. And frankly, we let the patient choose. This one we would probably present leaning towards an RPL&D, but we let the patient choose. And I've just got some talking points here, many of which we've touched on already. So the advantage with an RPL&D is that you'll actually know what was in the RPL&D in the retroperitoneum, whereas with chemotherapy, you may not really know what was there, and that can guide some future surveillance. As we know, and see, as you alluded to, an effective RPL&D, you can avoid any chemotherapy at all in the majority of cases, which is an advantage. If there were to be teratoma or chemo-resistant transformed elements in the retroperitoneum you didn't know about, you have the ability of resecting these up front and away. And you can argue that in general, it's a shorter journey. And so you just talked about the minimal morbidity of your RPL&Ds, how fast they're home when you compare that to 3 or 4 cycles of chemotherapy. If you can do an RPL&D monotherapy, I think the journey is much shorter than 3 or 4 cycles of chemotherapy. Of course, the disadvantages have been talked about: scar, complications you have to talk about with your patients, the chance, albeit low in primary, but loss of antegrade ejaculation, bowel obstruction. And then, of course, there's a chance of relapsing. And I think we've addressed this already, sort of advantages of giving upfront chemotherapy, but we have to acknowledge with the patients the disadvantages, and that is that a good number of these patients will need to go on and require a post-chemotherapy RPL&D anyway. And so you perhaps don't lose that much by going in upfront with an upfront primary RPL&D. And of course, we can't forget about the long-term toxicities of chemotherapy, which I think most would argue are less so than the long-term toxicities of an upfront RPL&D. So Sia, why don't I stop there? We'll leave the adjuvant story out of it for now, and the marker positive story we can pause for now. So I'll stop sharing and send it back to you.
Great, thank you, Rob. That was great. So let me get back to this and bring up a little bit of a more controversial issue. What if the tumor markers didn't normalize, but they were low stable? So AFP 25, beta HCG is 2, and let's say it's in the low normal range. Would that change your recommendation? Craig, what do you think?
It is largely unknown to any degree of certainty. We know from way back that we cured about half of stage 2C disease with big radical RPL&Ds without chemotherapy. Some of them were given adjuvant radiation therapy despite being non-seminoma, but I'm not sure that meaningfully changed their outcomes. It's never been the subject of scrutiny because for the last 30 or so years, people assumed that if they had marker elevation, that they were at risk for systemic disease beyond the retroperitoneum. But how big that risk is, at least in my mind, unknown. I think practically, if someone does not have rapidly rising markers or really very, very high markers, which is what you typically, as you see nowadays with active surveillance, is it's rare that it goes from 0 to 10,000 over a observation period, unbeknownst to the patient or provider. So if it's rapidly rising over several determinations, I generally think of that, and I'm not exactly sure of even those data, but I generally think of that as probably having a high enough risk for distant disease to treat that patient with primary chemotherapy appropriate to their markers. usually BEP times 3 in almost all cases, and then make a surgical decision after that. And in the upcoming study, we don't want to change too many variables as we try to prove these principles, but it would certainly be logical to me is in a secondary phase that we look at the group of patients with lowish abnormal but pretty stable markers and see if they behave more like a marker negative disease than the people with rapidly rising markers. It's just unknown in my mind.
Right, right. Christian, any thoughts? Any other thoughts?
No, I agree. I mean, a patient who has a non-seminoma and a stable AFP, it's very difficult to assess. I think in this case, if the AFP over several determination does not really clearly rise, it would probably not change my recommendation. It is, however, not a very common finding, but when you talk to Craig or to Larry Einhorn about this, I think Larry is very, very doubtful about an AFP, which is somewhere between 10 and 30. And if it does not clearly have a direction up or down, it could very well be that this AFP is actually entirely unrelated. As we know, a tumor-related AFP, usually, we don't have stable disease usually. So in this particular case, it would not change my recommendation. If it was rapidly rising, I would do the same thing. I would probably lean more towards chemotherapy. But with a stable AFP, a low-level stable AFP, I would probably still suggest that the patient would probably well be served with an RPLND.
Yeah, I think, yeah, we certainly agree. And you know, keep in mind, sometimes, particularly with cystic teratomas, they can sequester these tumor markers within the fluid and slowly seep into the bloodstream, although you see that mostly in the post-chemotherapy setting with these larger cystic masses. But I suspect that can happen in the smaller ones too. And I've certainly seen that where we do an RPLND and the tumor markers in the post-chemotherapy setting come right down. So let's move on to the next case. This is a 40-year-old gentleman who presents with back pain, firm mass on the left testis. He's got multiple masses. There is his tumor markers, and now orchiectomy, again, pure seminoma, LVI negative. But on the CT scan, you're seeing this. So you have the lymph node sort of in the retrocaval area. It's a little bit larger, encroaching like about 3 centimeters, and at least 2 to 3 positive lymph nodes there. So, you know, this is I think a different story. And Christian, let's start with you. Is this a case for surveillance, chemotherapy, or radiation?
So this is a patient who has a 3-centimeter mass. I assume he had a left-sided testis cancer with several satellite nodes around it. In my opinion, there is not really a lot of doubt that this is metastatic seminoma. If you want to, I don't think it will change the prognosis if you do another CT scan 6 weeks later and you just see that it's growing. But this is certainly a case where I would not have any hesitation to offer the patient chemotherapy with 3 cycles of BEP. For 2Bs, the radiation field gets relatively large. And we know that radiation in this setting has probably somewhere around a 7 to 10% recurrence rate. So we would discuss that in our multidisciplinary board, but I'm almost certain that the recommendation would be quite uniformly to send this patient to primary chemotherapy.
Okay, I'm going to have you give a few words. I'll stop. I know you have a few slides here, so you want to tell us your thoughts here?
Sorry, Sue, you broke up. You said Craig or me?
You.
Okay, sorry.
Yeah.
So I agree. I would have put the radiation relapse rate probably a little higher, maybe sort of 10, 15. Unfortunately, it's not advancing. There we go. So we would have certainly offered an equivalent discussion on these things. If there's multifocal lymph nodes in the retroperitoneum, we tend to lean towards chemotherapy for those patients. Size of the primary landing zone node doesn't scare us away too much from radiation. Once you get closer to 5 centimeters, obviously we get a little bit gun shy of radiation, but we are probably one of the more aggressive places in the world for giving primary radiation therapy for these retroperitoneal relapse or primary 2A, 2B disease for SEM. As for RPLND, which is what you asked me to address, Sia, you've already talked about it with the SEMS trial. What I tell patients is that, I think we have to acknowledge, and often they come and ask us about RPLND for seminoma now because it's in the social media, it's in the literature. I think you have to acknowledge that it is not guideline concordant as of now. As you showed, Sia, there are certainly case series data suggesting feasibility and safety, and there are clear advantages if you can get away with it safely, that you avoid the long-term toxicities that we know about with radiation and chemotherapy. But what I tell patients, and I won't go over this because you've gone over it already, and unfortunately I was just dialing in as you were discussing the prime test data, but we've only seen the interim data, but the relapse rate looks like it could be as high as 30% for those primary RPLNDs for seminoma. And as Christian made allusion to, we would anticipate with radiation a relapse rate of around that 7 to 10%, as Christian said, even lower for chemotherapy. And so that's what we're competing against with RPLND. Obviously, we need to wait and see what the SEMS data shows. So what I tell patients is that, and when people ask me about this outside of Princess Margaret, I say, I don't think that people should be offering this outside of a research protocol at the current point in time until we see the conclusive data from these 2 prospective trials that are ongoing. That's my take on it.
Okay, well, very good. We sort of have approached these pretty much the same way. Obviously, we've had the trial open, but the trial closed last year. We have still been offering it off trial with a shared decision making and a lot of discussion about. Of course, I'm sort of privy to the primary data, so I can at least qualitatively tell them a little bit of our preliminary results. So what you're saying is I better publish this soon so you can get back to operating, right? For these cases.
Exactly.
Okay, Craig, chemo or radiation for this?
So I basically agree that the reflex in this setting probably favors chemotherapy, and at least in my view, and I think the evidence points us that way, it's BEP times 3, not EP times 4. I would consider radiation in, I certainly consider chemotherapy as the primary go-to modality in the younger patients who happen to have seminoma, because I think they are more prone to post-radiation side effects than older folks. And if he were 50, I might consider primary radiation therapy and take the risk of the 10% or so risk of relapse requiring chemotherapy, because they would have likely have fewer years to develop radiation toxicities, and beyond 50, tolerance of chemotherapy is noticeably less, and he would have a rougher go. That's the only thing I would add.
Got it. Great. So let's move on here and just from the AOA guidelines, patients with stage 2B seminoma lymph nodes greater than 3 centimeters, chemotherapy is recommended. It's a moderate recommendation with evidence grade B. BP times 3 is what we prefer. I think the 4 of us here versus EP times 4 is or dog-leg radiation therapy. Both give you cancer-specific survival rates of greater than 97%. At least that's what's in the literature. No real differences between the treatment in that sense, but you just heard what the nuances are, and we all slightly favor chemotherapy because of the radiation effects for these. So Christian's absolutely right that the fields get larger, the effects of the radiation many are significant. For those of you who haven't been in a retroperitoneum that's been radiated 20 years prior, it's interesting the kind of effect it has and on the ureter, on the renal pelvis, on the kidney, and the retroperitoneal lymph nodes. I've done cystectomies and prostatectomies and nephrectomies and all kinds of reconstruction on these patients who've been previously radiated, as I'm sure, Rob, you have, and it's not fun. So
Christian or Sia?
Yes.
Could I just ask a question, being a dumb medical oncologist? My assumption, and you guys are always whining about having to do post-chemo seminoma cases, that it's sticky and it's all concrete and you have to work hard and all that sort of stuff. I assume that a virgin RPLND in a patient with seminoma kind of feels, acts, and looks like a non-seminoma. Is that correct?
Absolutely, and that's actually a great question, and a question that I get asked from a urologist doing seminomas now is, what does it feel like? And I can tell you, it's a very straightforward, easy case. This is nothing like the post-chemotherapy setting. One caveat is I would say for both seminomas and non-seminomas, you have to be real careful with the nodes to make sure you don't manipulate them and spill tumor, because some of these capsules of the tumor are very, very fragile, and you really don't want to manhandle this, which is one of the big reasons I don't advocate laparoscopic or robotic RPLNDs in this setting, because tumor rupture is associated with a really, really bad outcome. So that's the only thing, Craig. Otherwise, yeah, you're right. First of all, we always work hard in the retroperitoneum.
And we never win.
And but those are easy cases. Do you agree, Rob?
Yeah, no, I agree. They if you close your eyes, you think it's a non-stem, primary non-stem.
Exactly. Exactly. So let's move on to the last case here. 49-year-old. This is one of my own patients. History of HIV. Had anal cancer that was treated with radiation. Was cured and then presented with a right testis mass. Ultrasound showed the testis mass. I'm sorry, the tumor markers you see there. Orchiectomy. This is a non-SEM, LVI negative, embryonal and yolk sac PT1B. Now the CT scan shows this lymph node in the inner aortic cable area. To me, this was a pretty straightforward 2A. Initial CT was negative, by the way. This developed later with normal markers at 3 months. So I'll just move the story along and tell you that for 2A, I advocate RPLND, as we've been hearing. This is 2A non-seminoma. But when I got in there, and this scan was really only 3 to 4 weeks, as many of you know, when we go in there, you can have a lot more disease than you anticipated. And that's what happened here. I had 4 matted lymph nodes, and it was 3.5 centimeters in total. 4 of these nodes were positive, and I had some extranodal extension. So pathological stage 2B, and really now the question is, would you give adjuvant chemotherapy for 2B or 2C? We'll talk about. I'll have Rob give us his thoughts about indications for post-chemo RPLND. But I want to open this up to Christian and Craig. Is this a patient? Again, let's go back to the pathology here. Positive nodes, I forgot to put in there, extranodal extension. They're matted, came out fine, everything went okay. But is it worth giving adjuvant chemotherapy or just waiting for relapse?
Who do you want to start? Craig wants to start.
Okay. So you don't happen to know, did he get chemo radiotherapy for his anal cancer?
As far as I know, no, he just got the radiation therapy. He was early stage and he was cured from that.
And how long ago was that?
That was 5 years prior to presentation, and his viral load was negative at the time I saw him, and he was otherwise, he looked completely healthy.
Just like I suggested, it's never wrong to do a primary RPLND, or rarely wrong. It's rarely wrong to wait. This would be an interesting, and we'll find this out, but this would be an interesting one to have had microRNA on, and I don't know that we're at the point we could act on it yet, although if he relapses, if he's under close observation, he's going to relapse at a very favorable stage and probably be easily cured. I would wonder, he's the type of person that you'd think about that he's gotten a significant portion of his bone marrow radiated, and I would give him growth factors from the get-go. But I don't think he's at risk of dying of, much risk of dying of germ cell tumor recurrence. So I would give him the advantage of watching and waiting and see if he's cured with your brutish approach.
Would you, Christian, do you agree? Would you give adjuvant chemotherapy or wait, so 2 of BEP versus wait for relapse and give 3 of BEP?
Well, first of all, it's very dangerous to disagree with Craig. Second, yeah, no, I agree. I mean, as I mentioned before, in the hand of an experienced surgeon, and whether you're an experienced surgeon here or not, I'm not exactly sure how to judge that, but
for all these years,
I know there is probably a 70% chance for this patient to remain disease-free. And when you look at the adjuvant treatment, that means he would need 2 cycles of BEP. Now, there's probably a smallish difference in terms of toxicity and long-term toxicity between 2 and 3 cycles of BEP, but there's probably a pretty big difference between 0 and 2. So in my opinion, as Craig said, that if you adequate survey that patient, if the patient is compliant, the chances, if he relapses, this patient will relapse quickly. And the patient will relapse at a stage where he is at a very good prognostic level, and then he would be treated with 3 cycles of BEP, otherwise he would have needed 2. So I would wait, I would closely watch him, and if he really relapsed, I would give him 3 cycles of BEP.
I agree. I'll just tell you what happened here, and Rob, we'll hear from you in a sec. So he did relapse, and he relapsed very early, as you said. He relapsed at 3 months after the scan, 3 or 4 months, with slightly elevated markers, good risk disease, and he had a fair number of lymph nodes, both in and outside the template. I think part of the issue is the extranodal extension does increase your chances. But there is a finite cure rate, a good one at that, for even 2B. So it's worth seeing whether your surgery was therapeutic before giving adjuvant chemotherapy that either may not be enough for the relapse or too much for the patient who's not going to relapse. So I think we're all on the same page. Rob, do you have some words of wisdom?
Yeah, I know. I agree completely on the adjuvant chemotherapy side of the story. And at Princess Margaret, we were very aggressive about watching post-RPLND, pretty much regardless of the pathology. The only caveat is if you have transformed elements in your specimen, we are a little bit more aggressive in that case, but that's a different story than what we're discussing here. I agree with everything that's been said, and that's uncanny how the four of us sort of see eye to eye. Yet the guidelines are, you at least have to discuss it with the patient that adjuvant chemotherapy is what's indicated in the guidelines. And
right. So let's say this patient had a 2C, there's no controversy there, gets 3 cycles of BEP. What are indications for post-chemo RPLND, and do you think microRNA will have a role in that setting?
Sure. You want me to show some quick slides? I realize we have about a minute and a half, so
Well, we'll give you 2.
So, I mean, I hope that most of the indications are fairly rudimentary. So in 10 seconds, the concept is basically any residual disease over a centimeter should be excised. Now, unlike previously, if you have rising markers, you should start talking about second-line chemotherapy. If you have negative markers, absolutely go for your RPL&D. If you have low or stable tumor markers, as was mentioned by Christian, some of these cystic masses can harbor AFP and HCG, and so don't let that deter you away from doing an RPL&D. Obviously, allow the patient to recover. And just a couple pitfalls worth mentioning in 10 seconds that I see. Forget the PET and post-chemo non-seminoma. Forget the PET. It's not going to help you because it's useless for teratoma. I think we can all conclude that even the best of our models that have attempted to predict benign disease when present are not strong enough. They're not discriminating enough to avoid an RPL&D. And then if you're going to go in, you have to do a complete, ideally a bilateral template for a patient such as you discussed. Do not do a lumpectomy. You can argue a modified template, and there have been papers, Indiana most recently has looked at this for select patients. You can do a template dissection, but I think the main principles do not do a lumpectomy because you will run into trouble later with late relapse. 10 seconds on microRNA, or are we out of time?
Yeah, no, let's hear it. We've got a couple of minutes if you can wrap up with the microRNA in this setting, because I think it's going to be real interesting.
Okay, did my slides advance for you there?
Yeah.
Okay, so very fast. We've looked at this microRNA role in the post-chemo setting, predicting the histology at post-chemo RPL&D. So we've looked at the post-chemo microRNA, but pre-RPL&D microRNA. And what we found that was it was elevated in the patients who were harboring viable germ cell tumor, significantly more so than the patients who were harboring fibrosis or necrosis. But the punchline and the caveat is that unfortunately, in teratoma, there was no elevation of this one microRNA that we looked at here, which is 371A3P. We don't have time to get into it, but others around the world, most notably Christian and Craig and Lucia Nappi, are looking at trying specifically to address this teratoma issue through other microRNA, and hopefully we will have some more breakthroughs on that. But provocatively in this paper, we suggested maybe we could consider moving the post-chemo surveillance cutoff to 3 if you had a microRNA that was negative, because in our series, we had no viable cases of viable germ cell tumor when the microRNA was negative. Obviously, that's highly controversial, needs to be validated, and maybe with the help of 375, microRNA 375, we could improve on that principle even further. So why don't I stop there? And
Well, thank you, and I want to thank Christian and Craig for this fantastic panel discussion of stage 2. Always learn from you guys. It's amazing, and Rob, amazing work with the microRNA 371. Lucia, who I think is listening in, also has done a real tremendous job bringing the microRNA 371 story to light, and hopefully, like I said, the upcoming clinical trial will help elucidate the role in making these decisions for us a little bit easier for management, adjuvant therapy, when we operate and when we don't. So hold on. I think things will change over the next 5 years as far as guidelines. Again, thank you very much, Dr. Gill. Would you like to say some parting words?
Thank you all. Thank you, Dr. Hamilton. I'm glad you were able to get in. Excellent comments, enjoyed them. Thank you, Dr. Kollmannsberger, and thank you, Dr. Nichols. Great job, Sia, in putting this together. And again, another outstanding lecture series, really informative. As mentioned, this is going to be on the 60 Minutes YouTube channel, and where folks can go in and review this at their leisure. Thank you all again. And next week, we are going to be talking about rectourinary fistulae, robotic repair of rectourinary fistulae by Dr. Renee Satella's team. And again, thank you all. Great job.
Great. Thank you.
Bye-bye.
All right. Bye-bye.
Thank you very much.
Thank you.
Thank you.